Welcome, Nick Slenkovich, plastic surgeon in Denver. This is our Facebook live show, Journey Talk. Thank you for joining us. We always work in our practice to partner with patients on their self-improvement journey, and our guest tonight does the same in his practice and has been doing so for at least 15 years now. All right, I'm going to go ahead and introduce him. We're going to get started with a colleague of mine that I've known since medical school, Dr. Ethan Lazarus. Now, I know Ethan as a medical student. Really, probably first. You probably know me as a medical student primarily, right?
Yeah.
And so it's like anatomy lab. It's like pulling all-nighter, studying for tests and OB rotations, all of the various clinical rotations and that fun stuff.
Yep, we go way back.
I have more data on you here, though. Okay, so afterwards you've gone on and become a prominent physician in our community, but also nationally in your specialty of weight loss medicine. But before medical school, a graduate of University of Pennsylvania with a degree in healthcare administration. Medical school, we graduated together in 1996 from University of Colorado. Did residency in family practice, Fort Worth Family Medicine. Is that correct?
Yep.
Okay. And then afterwards, I understand you did practice in family medicine, but have now specialized for the last 15 years in weight loss-based medicine. And you're a member of the Board of Obesity Medicine, as well as the vice president of the Obesity Medicine Association, involved in various drug trials, or at least supporting the industry with its research into weight loss and weight loss studies in multiple areas. I know you've authored other papers and speak nationally and internationally on this on a regular basis.
Yeah, thanks. So that's very flattering. So I've definitely enjoyed my career. I'm mostly in private practice. I spend most of my time seeing patients. But I've really enjoyed the last 5-6 years being involved in Obesity Medicine Association. I do a lot of teaching, both doctors, but also people affected by obesity. Yeah, I mean, right now, if you look at statistics for America, 15% of America roughly, 10% of America roughly has type 2 diabetes, if I'm remembering my numbers right. And if we could help people lose just 5% of their body weight. So if a person's 200 pounds and they could lower their weight to 190 pounds, we would eliminate 2/3 of the risk for type 2 diabetes in the country.
People want to feel good, look good, and have a high quality of life, and weight can certainly get in the way of that. So I think there's a lot of issues from personal to medical across the board around weight and weight management.
Yeah, it's a nice way to think about it. So a lot of people just think about their weight, what's it on the scale, or what's the body mass index, and that's certainly important. But I always like to understand how the weight's affecting a person, not only medically. Obviously, with medically, we talked about diabetes and blood pressure and heart disease.
Yep.
Did you know there's actually 236 medical problems that have been identified as being related to weight, and 13 of them are cancers.
Right.
So we look at the medical issues, but then we look at the psychological issues. Weight can make people be pretty unhappy. We look at functional issues. Some people have trouble getting around, can't do the things we want to do, can't enjoy the Colorado outdoors, go hiking. And then physical issues. I mean, weight makes people tired, makes us have pain, have knee pain or back pain. And so usually as I'm getting to work with somebody, I try to understand those different areas. And if we're losing weight, we don't just want a lower number on the scale. I mean, that's not what we're after. I mean, we really want to improve quality of life.
I guess, how are you doing that? You're saying you're spending an hour with the patient, and you're saying you're going to identify what those key behavior interventions, as you're calling them, are going to be to give people tools to get through those situations. Holidays are coming up, relatives are staying with us. Those types of things is part of your behavior interventions.
That's right. So at that first visit, actually, I'll typically figure out what are we going to do, which food plan are we going to do, are we going to do a treatment plan, are we going to do medication, which one, and then typically I'll assign the dietitian to carry out the nuts and bolts. So after that first visit, usually people will see the dietitian weekly for 3 weeks, and then they'll circle back with me every 4th week. Okay,
and you mentioned medications. That's your fourth leg then?
Medication is the fourth leg on the chair, and in society it's the one that's least used. But for the person that has a lot of the fatigue issues, especially if they feel okay on caffeine, the phentermine's a really good choice. It's inexpensive. It's available at all the pharmacies. Yeah, I'll talk to each of those real briefly, actually. I think people want to know. Belviqu's, a newer drug, came out in 2012, and it's actually really calming. So people worry about phentermine because they can't sleep. The Belvique, you can take it before bed and you actually sleep better. And it works really well on the satisfaction system. So you know that sense you get when you start eating and then you're able to stop? A lot of people, as they get heavy, lose that stop sign and don't stop eating until the stomach is stuffed. So Belvique really, really helps. It's easy to take. It's once a day, very safe. They just published a 3-year safety study this week. Contrave is also interesting. So a lot of people just complain of irrational food cravings. I crave chocolate. I crave donut. I crave pancake. I crave peanut butter. And it's a really interesting drug. It's really taken this addiction route. People say, I'm addicted to, you know, whatever the food is. And so the Contrave, by combining these two anti-addiction drugs, and they're both very safe, very effective, not stimulating, is a very potent appetite and craving controller. So don't do a band. I definitely would recommend steer clear of gastric banding.
Yeah, I'm definitely seeing less, but I still see band, but I'm seeing less, I think, with the increase in gastric sleeve. The patients that I see, it seemed to replace some of the band population. So, but those are the most common procedures we see in this area: gastric sleeve, the Roux-en-Y, or the gastric bypass, and the lap band. There are other procedures that are a little bit more dramatic, like the duodenal switch, etc., but I don't see a lot of that in this area. And yeah, they're definitely very powerful tools. They do have good data behind them, but they are also, like everything we're presenting here, they are just a tool, and they are able to be defeated, and they certainly are not the answer by themselves. You might think of them as a very powerful and stable single leg to a stool, but it isn't going to provide complete balance, and is never going to be the complete solution by itself. And the best surgeons really do engage with a good bariatric support program, but even that, it still takes engagement, and it's not a solution just by having the surgery. Okay. Thanks for talking a little bit about surgery. I do think there's multiple situations out there, and not one fit for everybody. But I think the idea of medically based weight loss is successful for a large number of patients, and even patients that have had surgery and it hasn't been fully successful for them. Ethan, thanks so much for coming.
Pleasure.
I super appreciate it. Good night for us. Enjoy your journey.